So I'll just get a show of hands. How many people in the audience would be treating hepatitis C at the moment? Quite a few. Okay, that's good. Hepatitis C we've seen a really significant improvement in the treatment and the outcomes for these patients. So I'm just going to talk about a little bit of the epidemiology within Australia, some of the evolution in hepatitis C therapy, staging of hepatitis C, and really looking as to whether cirrhosis is present, treatment of hepatitis C in the primary care setting, the new drugs and their interactions, and then outcomes post-viral eradication. So we know that hepatitis C is an RNA virus. It replicates in hepatocytes. It's transmitted via blood, and the prevalence in Australia is about 1% of the population. But the majority of the patients in Australia will have genotype 1 or genotype 3, but this is no longer very relevant because most of the treatments, the two main treatments that we have at the moment, are pan-genotypic. So the genotype is less important unless we're dealing with resistance, which is quite uncommon. Most of the patients have early stage disease, about 90% are non-cirrhotic, and 80% in Australia are known, so they're known carriers of the disease. So about 4 out of 5 patients, the diagnosis has already been made. The symptoms vary. Most of the patients are asymptomatic, but the most common symptom is fatigue or arthralgia, generally feeling unwell, low mood, a bit of depression. These are all common symptoms. So that we know that once exposed to hepatitis C, about 60 to 70, 80% or so will develop chronic hepatitis, which means that about 20 to 30% will clear spontaneously. Out of those, over the next few years, or 10, 20, 30 years, about a third of them will go on to develop cirrhosis, and out of those, a significant number will develop liver failure or liver cancer. So there's quite a long period where we can treat, and we now know that this is a curable, all oral and easy to take medication. So in Australia, in 2017, there was estimated to be about 180,000 patients still with the disease, of which about 145,000 were known and recognised. And out of those, about 60,000 were treated, and the majority of those were cured. So we can see if we can get to these patients and offer them treatment, we're looking at a significant number of that. The problem is we're still seeing about 10, 11,000 new infections per year as of 2016 and 17, mainly related to ongoing intravenous drug use. And it's becoming more of an issue in our Aboriginal population as well over the last few years. So we've seen some significant improvements over the years. When I first started doing gastroenterology and hepatology, everybody needed a liver biopsy. It was feared, it was dreaded, it was extremely painful and high risk. So we no longer need a liver biopsy. And this was removed as a mandatory requirement back in 2006. And we saw a significant improvement in uptake in treatment once liver biopsy was no longer required. Now in 2016, when the new treatments became available, we went from treating about 3,000 patients per year nationwide to the first year when we treated about 40,000 within the first 12 months. This is a paper that I wrote when I was training as a registrar, and it looked at what we called the Share Care Clinic, which involved hepatologists, the GPs, the pathologist reading the liver biopsy, the nurse practitioners, a psychiatrist, a psychologist, a social worker, a huge team. This took up the whole clinic in the hepatitis clinic, and most of us will remember those days. Oops. Yeah. So we no longer need that, and now it's all managed predominantly in primary care. And we've seen a huge evolution in hepatitis C treatment from the initial interferon-based therapies. Initially it was called non-A, non-B hepatitis. It was known to respond to interferon, and then interferon became pegylated. In 1990, hepatitis C was first identified, and over the years we've seen continued improvements, but always very small and slow gradual improvements until approximately 2010, when the first protease inhibitors were discovered that could actually inhibit replication and then allow the immune system to clear the virus and achieve cure. So it's been about a 30 to 40 year history where we've gone from having a significant disease with a major healthcare issue to just taking 1 or 2 pills per day for 8 to 12 weeks and achieving cure. The goal is to actually eradicate and eliminate the disease in Australia by 2030, and it's thought to be that a combination of work from hepatologists, gastroenterologists, GPs, infectious disease specialists, but also nurse practitioners will have a vital role. When the new drugs became available in 2016, it was predominantly the hepatologists and the ID physicians and gastroenterologists that were providing the treatment. That's the blue column there. But we're now seeing that most of these patients are not making it to our clinics, and the majority are actually being treated in primary care. So we know it's easily treatable, and we know that eradicating the virus can prevent cirrhosis, it can reverse cirrhosis, it can reduce the risk of liver failure and cancer, and improve mortality. And with the new treatments, we're getting about a 95% cure. So let's go on to a case. This is a 28-year-old real estate agent. She's fit and well. She's concerned over her risk of hepatitis C, and she requests screening. And the reason is because she had a prior boyfriend who had known hepatitis C, who was hep C positive. So how would you counsel her? What would be her risk? They were together for about 3 years. Probably low, yep. So we explain that the risk of sexual transmission is very rare or very low. She denies injecting drugs, which is an important thing to ask. So the risk with sexual exposure is extremely rare. There are some instances, particularly in men who have sex with men, who do have a higher risk of hepatitis C transmission. So a second case, this is a 33-year-old female who now presents. She's 14 weeks pregnant, and when she says that she was exposed to hepatitis C, that she used intravenous drugs as in her late teens for about a 2-year period. She was diagnosed about 10 years ago, but never treated. Declined treatment at the time because she was concerned over side effects. She now has a stable life. She's married. She does FIFO work with BHP and operates machinery. So she's regularly tested for drug screening, and she's never tested positive. So it's obvious that she's no longer using drugs. But she's very concerned regarding transmission to her child. And she's asking, can she have treatment now at 14 weeks of pregnancy, and what is her risk of transmission? So any thoughts there? No, can we? So it's because there is a little bit of confusion with this, because with hepatitis B infection, we do offer treatment during pregnancy to prevent vertical transmission in the 3rd trimester. Whereas in hepatitis C, unfortunately, the antiviral treatments are teratogenic, so they're contraindicated, so we cannot treat during pregnancy. But what is her risk of transmission anyway? Is it significant? Is there anything else we can do? So luckily, it's not very high. It's less than about 5%. But that's still about 1 in 20, so it's not insignificant. It's not zero. And is there anything we can do? Unfortunately, no. So neither cesarean section, there's no treatments or anything. So we just recommend that once the child is a little bit older, after 6 months or onwards, they can be screened to see if they have hepatitis C. And it is now licensed in, Mavorite is licensed in children in Australia as of from age 12 onwards, so adolescents, yeah. And that's a new thing, Jean? Yeah, just now. So when screening, there are certain risk factors that we should consider. So obviously the history is that of intravenous drug use or sharing of snorting equipment. Sometimes people will deny injecting, but they do have used drugs, and a lot of the times they have snorted drugs. They come from a high prevalence country or region, mainly in Vietnam or Asia. There are quite high rates of hepatitis C, also in Southern Europe. Blood transfusion before 1990, unsterile tattooing or body piercing. Any people that have been to prison have a very high rate, and associated needle stick injury in healthcare workers. Household transmission is very rare. And as I said, sexual transmission is also rare, but it can occur in certain populations. People with abnormal liver function tests or who present with jaundice. So let's go to an older man. It's a 52-year-old man, Neville, who comes. He works as a landscaper. He owns his own business. Sorry, that's come out very small. He injected heroin from 83 to 85. But none since then. He's concerned that he may have hepatitis C. He's never been tested in the past, but he drinks regular alcohol. He's concerned over the treatment side effects and his ability to work. So what test would you do as an initial test for screening? So hepatitis antibody testing as well as liver function tests. And how would we confirm that he is indeed infected? He's still, so we do the PCR, the RNA. And you can also do the genotype. So anything else in his history that he's mentioned there that may concern you? Alcohol, yeah. So there's a couple of things. One is the alcohol consumption. And the other is his age, because he's 52 and he's infected in the 80s. So he's got about a 35-year history of disease. So that's the duration of disease is important. So alcohol and hepatitis C, when we first started treating, we used to say that people could have 1 or 2 drinks a day in hepatitis, but these days we know that people with chronic hepatitis really should not drink alcohol or just limit it to very special occasions, because it does increase the risk of disease progression and liver cancer. So Neville comes back with his wife, and she has a number of questions. She also has everyone tested in the family, including herself and the children, and they're all negative. But she wants to know, how bad is his liver? We've spoken about alcohol. Should he stop drinking? The answer is yes. He's overweight. He doesn't exercise. Is this important? He has genotype 1 hepatitis. Is this what is it, and is it still relevant? So any thoughts about those questions? Sorry? Lose weight, exercise, yeah. So the obvious things, but it's really getting at the fact that he's probably got more than one liver disease, because he's got chronic hepatitis, he's probably got fatty liver disease because he's overweight or obese and doesn't do any exercise, and he's a drinker. So, and with 35 years of infection, he's almost certainly going to have, if not cirrhosis, advanced liver fibrosis. So looking at the natural history, we would know that things like co-infection with Hep B, HIV, or fatty liver or alcohol really increase your risk of progression. And if we look at the time, we know that by 30 years duration of infection, there's a 50% chance that your patient who's sitting opposite you is cirrhotic at the time. So just right off the bat, we know that he would be very high risk. There are 4 key questions to ask. First of all, is cirrhosis present with regard working up to treatment? Is the patient treatment naive? Have they had prior treatment, and what sort of treatment? Could he be co-infected with HIV or hepatitis B? And are there any drug-drug interactions that we have to worry about? So we've sort of touched on this already, but we do antibody testing, and then if it's positive, we'd then go on to do the PCR For patients that are actively injecting drugs, there may be about a 3-month delay to develop antibodies, in which case you'd need to do the hepatitis C RNA, which should be positive right away. And people who have ongoing exposure or ongoing risks, such as injection drug use, should be tested annually. So how do we know the stage of liver disease and is cirrhosis present? So we can do a couple of blood tests like the APRI or the HEPA score, and they're available both through most of the labs here in Perth. HEPA score was developed at Charles Gardner Hospital by Professor Leon Adams, and that's quite an available test. And then there's also ultrasound elastography, which is available through most of the radiology practices. And for the tertiary hospitals, there's a FibroScan, which measures the degree of liver stiffness and correlates quite well with the degree of fibrosis. Yes?
I have two questions. Can you explain what's the difference between FibroScan and ultrasound elastography? And is there any sequence we should follow, like requesting ELA score or average score before going to FibroScan or elastography, or we go straight away to, for FibroScan or elastography? Because probably this can show a false negative in ELA score, I think.
Yeah.
Well, we feel patient with high ELA score, but when you do elastography, is negative.
There's no, yeah. So the question is, can I elaborate on the differences between FibroScan and shear wave elastography or ultrasound elastography? The next part of the question is differences between APRI and HEPA score, or what to do in the cases where you have conflicting tests, where one is high and the other one is low.
Why we should not go to the more accurate test, which is
right. Well, and why? Which of the tests is more accurate? Right. So first of all, it's good to do the tests that are very easy to access. So the blood tests are available and easy to access. The ultrasound and elastography is available and very easy to access. As far as accuracy goes, we like to combine all 3 or 4 tests if we can. FibroScan is very hard to access because it's only available through the tertiary hospitals. So a lot of the times you won't have access unless you refer them to the hospital, and then they have to be done via the hospital. In general practice, and what I tend to do, even in my rooms where I don't necessarily think the patient needs a FibroScan, I'll just use APRI, HEPA score, and ultrasound elastography, right? And using the combination of those 3, I can usually work out and the duration of disease. I can usually have a good idea of who's likely to be cirrhotic. Okay. Now the difference is FibroScan and elastography both look at liver stiffness. There's slight different technologies, but they basically look at shear wave technology. One's an ultrasound beam, the other one is some other sort of pulsed beam, and the blood markers look at various parameters in blood. Like APRI looks at AST to platelet ratio. HEPA scores a number of 5 different things, such as hyaluronic acid, bilirubin, AST level, etc., and it's all plugged into a formula and you get a number. So they're all quite good for excluding cirrhosis. So if you get very low readings, then they're very good for ruling out cirrhosis, which is really what you want to do. If they're in the middle, they're not that helpful. And if they're high, they're good because they're helpful, and they'll tell you who's likely to have cirrhosis. So that's kind of how I use them.
So can I just ask, just off topic maybe, but other causes of cirrhosis, and are those tests valuable, and if not, why not?
Yeah. So the question is, are those tests helpful in other causes of cirrhosis, non-hepatitis C related? Yep. So the answer is yes, they're quite good. They've been validated, like for example, HEPA score has been validated for hepatitis B as well as for fatty liver. They're not quite as accurate as they are for hepatitis C, I'm not sure of the exact reasons, but it can be quite useful, particularly HEPA score. And The elastography is also quite helpful for other diseases aside from for hepatitis C. But most of the data, most of these were developed in the hepatitis C era, so we have a lot more studies and information pertaining to hepatitis C rather than other liver diseases. So when referring to a specialist, we've covered most of these, the presence of cirrhosis, co-infection, chronic renal impairment, potential drug-drug interactions, and if you're worried about any of those things, then you're welcome to either give us a call or to use the remote referral form, or those who've had experience with treating a few patients will probably just get on and treat. So getting back to Neville's results, these are his liver function tests. So his ALT is 108, AST of 188. So straight away we see that the AST to ALT ratio is high, and if we go down to the platelets, it's low. So his APRI test, looking at the AST and platelet ratio, is very likely to be high. His gamma GT is high, probably reflecting alcohol and fatty liver. He's got normal coagulation, and so his synthetic function and bilirubin, the synthetic function is likely to be normal. And he's got normal renal function. His ultrasound, so his HEPA scores come back high at 0.9, his APRI is 2.7. We start to worry when it's greater than 1. And the ultrasound shows coarse and liver echo texture, but no splenomegaly and no sign of varices. And the elastography is approximately around stage 3 fibrosis. So he definitely needs treatment, we would all agree on that, and all the numbers point to advanced liver fibrosis, probably not cirrhosis, but probably very close. We have two options for treatment. We can use either Epclusa, which is a combination of sofosbuvir or velpatasvir for 12 weeks, or Mavorite, which is glecaprevir and pibrentasvir for 8 weeks. They're both equally as effective. The 8-week treatment course is a bit shorter and a bit easier. They're both very well tolerated, and I've used both. The main determinant for what I use in a particular patient comes down to drug interactions. So there's this amazing Liverpool website, which now has been an app on your smartphone, and you just put in the medications that you'd like to use, and it just gives you either a red, green or amber conclusion. And the red, obviously the drug should not be co-administered. The green is go ahead and treat. And some of the examples of things that we worry about, for example, is the oral contraceptive pill, and the use of Mavorite is contraindicated in these patients. Some of the other ones, some of the anti-epileptic drugs, if we worry about interactions with Epclusa, the proton pump inhibitors sometimes. So it's hard to remember everything, so obviously we use this application. Is everyone familiar with the app? Anyone who's treating hepatitis C would be using the Liverpool app? No? Okay, well it's very good. I strongly recommend it. So he's worried about side effects and will he still be able to work? So the answer is yes. Most of the patients can work. There's a very low rate of very mild side effects that include headache, fatigue and nausea. But we look at placebo, there's only a very slight increase compared to placebo for these symptoms. So the side effects are very mild. Some of the drug contraindications which I've touched upon for Mavorite include things like rifampicin, atazanavir. Some of the statins you will commonly come across, like atorvastatin and simvastatin, dabigatran, and estrogen, the estrogen pills. So the options are to, for example, if you've got a patient on a statin, you have the option of dose reducing the statin, or you can give them an 8-week holiday off the statin if you're going to use Mavorite. You can reduce the dose of digoxin, for example, if they're on digoxin. And if you put in these medications into the app, it gives you the exact instructions of what to do. So Mavorite has the advantage where you can use it with the proton pump inhibitors without having to interrupt people's proton pump inhibitor therapy. So follow-up, Neville comes back after 6 months. He's completed treatment. His liver function tests and hepatitis C RNA are repeated at week 12. And because he's got advanced liver fibrosis, this is somebody that I recommend should have 6 monthly screening with alpha-fetoprotein and ultrasound, because he's very likely to have advanced liver fibrosis. And he should be counselled regarding ongoing alcohol use, which he still has to be very careful with. So any questions on that case? Yes. His wife?
Should we advise against unprotected sex, or they should use protection until he's negative?
Yeah, so the question is, should we advise the wife against, give her advice regarding protected or unprotected sex while he's still viremic, right? So they've been together for about 20 years and she hasn't contracted hepatitis C so far. She's very unlikely to get it now. So there's no reason for them to change anything that they've been doing over the last 20 years. Okay. So to summarise, we need to screen and think about hepatitis C in at-risk patients or those with elevated liver function tests. Treatment is now much easier, 1 or 2 pills a day for 8 to 12 weeks with very minimal side effects and very high cure rates. And for patients who have confirmed hepatitis C with the RNA, there are 4 key steps. As I said, stage the liver disease using the modalities that we've talked about. Is the patient treatment naive, and is there a risk that they may be resistant, in which case they should see a specialist or the liver clinic. Check for drug interactions to make sure we don't cause any toxicity, and then follow up and confirm eradication 12 weeks post-treatment. And in the longer term, think about cancer. Unfortunately, we can't fully discharge these patients, particularly if they've had a long duration of disease. They are still at risk of liver cancer, and I'd recommend ongoing ultrasound and alpha-fetoprotein for at least the next 5 to 10 years. And if they're still drinking, then we may even need to think about longer screening for those particular patients. So, thank you. All right, thanks. Good. All right, I'd just like to wrap up. Thanks, everyone. I'd like to thank AbbVie, particularly Jean and Nikki and Leanne for sponsoring the evening. Thank you, everyone, for coming. It's great to see everyone. And please give us some feedback and let us know any other particular topics that you'd like to see in the future. Thank you.